Thank you, Flor, for the kind introduction, for being with us this evening. And thanks for all the speakers for being with us today. And I'm excited as everyone of the audience to be sharing with this webinar, tackling a very interesting and a very important subject, which is the periorbital rejuvenation by fillers. And who will be better than Dr. Javier from Spain to pave the way for the proper understanding of what we are going to perform for our patients by describing the periorbital anatomy on how to avoid complications during injections. Please, Dr. Javier.
Okay, thank you for this kind of introduction. I mean, I'm not going to explain nothing that is strange. I mean, everybody knows about the anatomy of the periorbital region. The fact is, we use these 3D models. For those who want to have these 3D models, they can go to the IMCAS Academy Marketplace, and they can have it. You know, all these 3D videos that you are going to see, during my presentation. So one of the most important things for me is what I always said about practical anatomy. You know, I do recommend to have this book from Dr. Jelks. I don't know if someone know that Dr. Jelks was my mentor, and right now he's my partner. You know, we organize meeting on oculoplastic surgery. But he wrote a book in 1985 that is the basics, on anatomy. So I strongly recommend, to have this book for those who are familiar and believe that everything is new. Nothing is new. So let's have a look, on this, on these books. So one of them, for me, very important thing is we have to move what I call from descriptive anatomy to practical anatomy. What does it mean? Anatomy is on the books, but then we have to move. We have to play with this anatomy. So my focus today is always is going to be on practical anatomy. So why to do this anatomy? Because we have to avoid two types of complications. We have to avoid vascular complications and aesthetic complications. So vascular complications are, related to the zones we described with Dr. Jugs, several years ago, in 5 zones. So that would be, zone 1, that would be supraorbital. Zone 2 would be infraorbital, and zone 3 will be, the internal canthus, and zone 4 in the lateral canthus, related with the temple. So this is just to have a matter of, to organize, the periocular area. So the upper lid, we have important things. We have, these 3 lamellas, as you can see here, where these lamellas, we have 3 important ones. So we have the external one is, the skin and all the, what we call skin and orbicularis. Then we have what they call the mid lamella is the tarsus, the orbital septum, and the fat. And then finally, we have for the posterior lamella, we have, the lid retractor, is the levator aponeurosis, and the conjunctiva. So the fact is, all this is very important, because the globe is, the eyelid is related, to the movement. So whatever we do affects, this region. What happened at at zone 1, as you can see here? In zone 1, you have, I'm sorry for that. In zone 1, we have 3 important issues. We have the supraorbital, vascular pedicle that can be superficial and deep, because everybody knows the notch that we have, the supraorbital notch. But there's another, branch of the artery that comes very superficially. Then we have the supratrochlear artery, and then we have another one that comes from the angular artery that it's the paracentral artery. So these 3 arteries are very important, when we do any kind of analysis and we do any kind of injections. So for those who believe that when we touch, the forehead, we have to be deep, because if you go deep is safe. Be careful. We have deep arteries, close to the bone, and at the same time we have very superficial arteries, close, to the muscle. So this is very important to keep in mind. Zone 2, as you can see here, this is from, our publication in I think it was in 2014. We have this infraorbital branch. We have the zygomatic facial and the angular artery. So this here, if you look carefully, this small artery here, this small artery is not the infraorbital artery. This is just a small branch that connects, all the marginal branch of the inferior arcade. We have just one artery, at the lid. The upper lid has two arteries. We have the marginal and the peripheral arteries. But this one, this for those surgeons who do transconjunctival approach, sometimes this is visible. And where is located this small artery? If you make a line between the pupillary line, internal line, is where it used to be. All right. So for those who do injections at the tear trough, for those who do the cannula, even the cannula, can injure this. Keep in mind, this small artery is not the infraorbital artery. I want to say again, it's just a small branch. The lower lid, again, the lower lid has three lamellas. We have, the skin and the muscle. Then we have a mid lamella where we have, the tarsus, the orbital septum, and the retroseptal fat pad. And then we have the capsulopalpebral fascia, the retractor of the lower lid. And then we have the conjunctiva. So all these, components are important when we treat, for example, the tear trough and the what they call in French language, the CERN. Why? Because when we what happened is when the arcus marginalis, that is the fusion of the orbital septum to the bone, it makes some spread, from the orbital ligaments, is when we have, this appearance of the tire, because we have the tear trough. So is where we are going to locate, our product. So there are different, of course, there are different techniques, as I will show you, between this. Then be careful with the buccal branch. The buccal branch need to be preserved. Why? Because the buccal branch is the main branch for what? For the orbicularis. The orbicularis is a three muscle muscle where you have the tarsal, the preceptal, and the orbital muscle. So, and it comes from above. So whatever you do from below, you're safe. But whatever you do from above, you can injure this. For those who like to do with needles, be careful, because this, if you injure this, you can have, a very important problem. Another very important thing that I will do again is that the orbicularis of the muscle is not a sphincter muscle. Is not a sphincter muscle. It has its own insertions at the medial aspect. All right. So in zone 3 is as you see here, is the internal canthus. We have the angular artery, the dorsal artery, and the infratrochlear artery. So all these arteries here, as you can see here, all these arteries this is the angular artery, this is the infratrochlear artery, and this is, the supratrochlear artery. So, and what does this is, in this region here is the paracentral artery. So if you look carefully, all this joins what? The ophthalmic artery. So be careful, all right? Then if we move to zone 4 is the one, linked with the temple. We have to be very careful too. Why? Because we always care about the superficial temporal artery, but we never care about the deep temporal arteries. And we have two deep temporal arteries. We have what we call, the anterior deep temporal artery, as you can see here. And then we have the lateral one. And if you look carefully to this one, is linked with what? With the lacrimal artery. So whatever you do here, as so many times, and I will show, thank you to Marina, an image when you inject in this region and you can have some blood. So temple area, again, the temple area that is linked, with the fore area, as you see here. So we have to be very careful. Look how, the middle deep temporal artery is linked, you know, with the periorbital, lateral periorbital area. So whatever you do here, you can be very unlucky, and you can injure this artery, and then you can have an hematoma. So this is, thank you, Marina, for giving me this opportunity. This is Marina, you know, an expert, you know, doing this. So look, blood coming out. So I do not recommend to use needles. This is my point of view. All right. Then, why all this? Because this belongs to what I call the ophthalmic, you know, angiosome. All this belongs to the ophthalmic angiosome. And the ophthalmic angiosome is linked, you know, with the ophthalmic artery. So whatever you do in this region, be careful, because what happened, as you will see here, we have an important issue that when the patient does, you know, the diastole, you know, even if you think you are injecting into an artery, you know, you can have a retrograde effect. And this should be normally, but in a diastole, you know, the product can go into the facial artery, you know, and then cause a blind effect. All right, so keep in mind this. Then from anatomy, from the aesthetic point of view, we have the temple area. I'd never recommend, you know, to go down to the bone. This, for me, is the safest technique is to go between the two fascias, between the deep and the temporalis fascia, is because when you go down to the bone, first of all, you need more product. Second, you have, you know, a space between that, as everybody knows, you know, the temporal muscle, you know, inserts at the zygomatic arch. And you, for those who has backgrounds in craniofacial, they know that the Gillies maneuvers, when you have a zygoma, you know, a fracture, you use, you know, this deep access to you know, to lift the bone. So if you inject in this region, the muscle, the temporalis muscle moves, so you can have some migration of the product. So this is what I don't, it's a standard procedure. I know, I don't recommend it. All right, in between. Then for the tear trough need to be, you know, is a matter of periocular shadows. So whatever you do, you need to to give these shadows in a certain way. So when we treat this, the tear trough is composed by two big elements. This is the deep mid-fat pad and the tear trough itself. It's not just one element. You cannot treat the tear trough just with one single shot, because whatever, if you push your fingers, you know, if you push your skin up to the tear trough, you will see that some tear trough diminish. At least mine diminish. I don't know yours, but mine diminish. So the fact is, it's like when you do makeup. If you just feel, you are feeling a depression or groove. But if you blend, it's like the makeup. So it's very important, you know, to make the differentiation. This is standard one. It's just feeling. You know, this is just YouTube random resource. I don't know. I took this from YouTube. But even in standard two, it has been, you know, published at the PRS, you know, just feeling. What happened when you just feel? You can have what they call the sausage effect. It's not fat, remember, it's hyaluronic acid, it's different, all right? So you have to be careful with this technique. Then what happened? If you can have this you know, this sausage effect, as you can see. Then even in Spain, they have published, you know, an article, you know, where they inject just, you know, parallel, you know, to the, I mean, just following the tear trough. So what happened is, if you look, this is an actress that has been injected in this way, and then you have this sort of problems. This is the orbicularis oculi muscle. Look to that. The axis of the orbicularis is in this region. If whatever you inject, if you inject, you know, following the axis, you increase the axis of the problem. But if you go, you know, perpendicular to it, you won't have any problem. All right. You are blending. The fact is to blend is like this one. You know, when you blend is like on the right one. But when you blend, you do. You know, it's like every woman in the morning it blends. It doesn't feel, you know, the tear trough. All right. This is my point of view. Let me go faster. So function for me is the most important result, but anatomy is the most, for me, is the most important factor. So conclusion, remember what I wrote, about the why, where, what, and how. Why, prevention. Where, anatomy first, filler after. What, understanding the filler rheology and science. And how, cannula versus needle. All right. So this is my conclusion about, the practical anatomy about, the periocular region. So I invite you all to come to the Academy to Mallorca. We have recently, made an agreement with the University from Naples. So you are welcome to do your cadaver dissections and whatever you want, even enjoy the beaches. Okay, so thank you very much for be part of this excellent webinar.